Good evening, everybody. Welcome to the online MOS BOA Journal Club meeting. Dr. Vaishal Kinia and Dr. Parul Deshpande for conducting this meeting bi-monthly. And today we have a case from BJ Medical College, Pune. And the discussant will be Dr. Smita Mohod Madam, who is Associate Professor at BJ Government Medical College. And I would like Dr. Vaishal to take over and introduce all the speakers and the guest speakers as well. Over to you, Vaishal.
Yeah. Thank you, Dr. Santosh. And this has been a very good virtual platform to discuss the Journal Club meeting we have been conducting for this is a second consecutive year. And the whole purpose is to sensitize the general ophthalmologist as well as the PGs what the prevailing topics are and which are of importance in their day-to-day ophthalmology. So without further ado, I would ask Dr. Parul to introduce our distinguished faculty and take the Journal Club meeting forward.
Thanks, Dr. Vaishal, Dr. Santosh. So this is our combined MOS and BOA Journal Club meeting. Today we are going to discuss about the role of HROCT in OSSN and the ocular surface metaplasia. So it was presented by Dr. Tejas, who is a PG resident from BJ Medical College. And this session would be co-moderated by me, Dr. Parul Deshpande, and Dr. Smita Mohod, who is also the Associate Professor at Pune BJ Medical College. So we have two eminent panelists here, Dr. Swati Kalki and Dr. Swapnil Balkar, who is from Pune. So Dr. Swati Kalki, as we all know, is the head of the ocular oncology team at L.V. Prasad Eye Institute, Hyderabad. She's a great academician. She's a great surgeon. She has a lot of present publications in peer-reviewed journals. I think about more than 230 publications, more than 250 presentations in national and international forums, more than 30 chapters in the textbooks. She is also an editor to two popular ocular oncology journals. And she's the brain behind Walkathon. I think, no, it's Whiteathon. So that is the running event that L.V. Prasad Eye Institute conducts every year for raising the funds for retinoblastoma children. So with this, I would welcome Dr. Swati. Dr. Smita?
Yeah, it's my pleasure to welcome Dr. Swapnil Balekar, who is a very well-known cornea specialist in Western Maharashtra. He is only surgeon in Maharashtra who has performed type 2 LVP K-Pro for SGS. We refer so many patients to him from BJ as well. He is, I would say, a great support to us. So without further delay, I think Dr. Tejas can start sharing his screen and start his journal presentation.
So we have two statisticians who will be joining us. So one is Dr. Siddharth Kesarwani, who is a pediatric ophthalmologist practicing in Mumbai, and Dr. Sabyasachi Sen Gupta, who was an associate editor for IJO. So welcome, Dr. Siddharth, and I think Dr. Sabyasachi will join later. Yeah, Tejas, you can share your screen.
Yes, okay. Shall I start now? Hello.
Yes, yes, please.
Good evening, everyone. First of all, I would like to thanks for Maharashtra Ophthalmological Society and Bombay Ophthalmologist Association for providing me such a great platform for presenting the journal. Today's journal is from Cornea, and myself, Dr. Tejas Kurgiva, resident doctor from BJ Government Medical College, Pune, The moderator is Dr. Smita Mohat and coordinator is Dr. Parul Deshpande, and panelists for today's journal is Dr. Swapnil Balekar and Dr. Swasti Kalki. Today's statistical expert is Dr. S. N. Gupta and Dr. Siddharth Keshavani, and Journal Club Committee Chairman is Dr. Vaishal Kenya. Uh, Title for my today's journal is Clinical and Optical Coherence Tomography Comparison between Ocular Surface Squamous Neoplasia and Squamous Metaplasia. Author for the journal is Shalin Stevens Daniel Rice. This article has been conducted. The study has been conducted in Miami Veterans Administration Medical Center and Bascom Palmer Eye Institute in between 2016 and 2020, which was published on 8th of April 2022. The impact factor of the cornea journal is 3.152. The purpose of this study was to compare the clinical characteristic and high resolution OCT findings between corneal squamous metaplasia and ocular surface squamous neoplasia. Introduction. Ocular surface squamous neoplasia represent a spectrum of epithelial squamous malignancy ranging from dysplasia to invasive squamous carcinoma, which affect both cornea as well as conjunctiva. This is the most common ocular surface tumor in adults, typically located in interpalpebral area, commonly at the limbus. Risk factor for the OSSN is exposure to sunlight and UV light, as well as human papillomavirus infection, systemic immunosuppression, and smoking. While the risk factor for the metaplasia are chronic ocular surface inflammation, xerophthalmia, vitamin A, as well as zinc deficiency. OSSN typically present as a limbal lesion with irregular border and hairpin configuration vessel at 3 o'clock and 9 o'clock. May have leukoplakic or gelatinous feature. Here you can see the dilated corkscrew vessel and the white leukomatous opacity present at the limbus. This is the gelatinous type. There are other types of OSSN that are leukoplakic, nodular, diffuse, and pigmented. However, the presentation can be variable and clinical examination cannot always reliably distinguish OSSN from benign lesion. On HROCT, three key features of OSSN are hyperreflectivity, thickened epithelium, and abrupt transition between normal and abnormal epithelium. Here you can see the arrow arrow showing that abrupt transition between normal and abnormal tissue, and the asterisk showing that thickened epithelium with hyperreflectivity. These features have been shown to have 94% to 100% sensitivity and 100% specificity for diagnosing the OSSN. HROCT has also been shown to aid in detection of OSSN in an individual with concomitant ocular surface disease such as corneal scarring, limbal stem cell deficiency, and plasmal nodular degeneration. HROCT has been used to help monitor the disease resolution because it can highlight the areas of residual subclinical disease, preventing the early termination of topical chemotherapy. HROCT can assist the surgeon in obtaining the appropriate margins at the time of excisional biopsy. Overall, HROCT has become a valuable tool in all stages of a disease process, assisting with the tumor diagnosis, monitoring the effect of treatment, and examining for disease recurrence. Although HROCT is a powerful addition to the workup and the management of OSL, there are instances of non-neoplastic lesion presenting with characteristics similar to OSSN on imaging. Here we have 4 cases of the squamous metaplasia that are indistinguishable from OSSN on HROCT. These cases required the incisional biopsy and histopathological examination to differentiate between metaplasia and neoplasia. In materials and method, it is a retrospective case control study which had 8 patients with the clinical findings suspicious of OSSN were evaluated with HROCT and eventual incisional biopsy with a chart review from 2016 to 2021 with captured history, examination, and histopathological result. Among these 4 patients, two are whites and 2 are black, had biopsy-proven squamous metaplasia, and the patients who had biopsy-proven OSSN all are white. In these cases, epithelial thickness of each suspicious lesion was quantified by comparing it with the normal epithelium in the same scan. An incisional biopsy was performed at the slit lamp in all the patients with most of the visible abnormalities removed. Margins were not prioritized, and neither the absolute alcohol nor cryotherapy was used at the time of incisional biopsy. All the patients with biopsy-proven OSSN received the topical chemotherapy for the residual disease after incisional biopsy, and the lesions are themselves were not vascular, and no feeder vessels are noted on examination. The first case, a 72-year-old black male with a history of 20 packs per year smoking, presented with a left nasal lingual opacity at 9 o'clock. Here you can see a single nasal opacity with a smooth round borders. On HROCT, it shows the feature of hyperreflectivity, thickened epithelium, and abrupt transition between the normal and abnormal epithelium. On histopathological examination, it discloses acanthotic mucosal epithelium with a focus overlying the keratosis. Here you can see the keratosis denoted by the asterisk, and the melanosis without a tibia present at the basal aspect of the tissue. The upward directing arrows are showing that there is a melanosis. The patient was started on topical interferon alpha 2 beta. After 1 month of the treatment, there was no change in the lesion, and the biopsy was performed, which demonstrated squamous metaplasia of the cornea and melanosis without atipia of conjunctiva. The second case is 83-year-old white male with a history of excessive sun exposure, presented with a bilobe left opalescent nasal limbal opacity. Here you can see the bilobe opacity at 8:30 o'clock. Again, HROCT findings are like same hyperreflectivity, thickened epithelium, and abrupt transition between normal and abnormal tissue. The epithelium of the limbal conjunctiva was normal. Histopathological examination discloses acanthotic epithelium with a squamous metaplasia and melanosis with tibia overlaying the substantia propria that contain moderate to marked amount of a solar elastosis. Here you can see the solar elastosis. Again, the third case of 61-year-old white male with a bilobe left corneal opacity with mostly smooth borders. Here you can see the bilobe opacity with a smooth border, and HROCT shows the same feature as previous two cases show. Biopsy examination demonstrates squamous metaplasia of the cornea and melanosis with no dysplasia, overlying substantia propria that contain a mild amount of the solar elastosis. The fourth case is of 48-year-old black female with a history of excess sun exposure, presented with a left opalescent gelatinous inferotemporal limbal corneal lesion with irregular borders. In this case, there is a location is inferotemporal. HROCT showing a thickened hyperreflective epithelium without abrupt transition. Previous three cases showing that there is a transition between normal to abnormal, but in this case there is no evidence of abrupt transition. Only thickened epithelium and hyperreflectivity has been seen. Histopathological examination discloses acanthotic epithelium with squamous metaplasia, overlying the substantia propria that contains solar elastosis and chronic inflammatory cell infiltrate. A 76-year-old white male with a right slightly elevated inferonasal limbal corneal lesion with irregular border. HROCT shows same three features, that is thickened epithelium with hyperreflectivity with abrupt transition between normal and abnormal epithelium. Histopathological examination discloses conjunctival epithelium with faulty maturational sequencing that extend up to full thickness. Here you can see in between two arrows, there is a full thickness involvement. That means it is a carcinoma in situ, and the patient has been received 4 cycles of topical 5-fluorouracil 1% with the complete resolution of OSS. Another case is 68-year-old white male with a history of basal cell carcinoma, and also the history of smoking, presented 8 packs per year with right corneal nasal opacity at 3 o'clock. Here you can see the opacity with mostly smooth borders. Again, HROCT shows the same findings, and histopathological examination discloses the faulty epithelial maturation sequencing extending up to half of the thickness. That means it is a type of corneal dysplasia, moderate dysplasia. The patient has been treated with topical interferon alpha 2 beta for 3 months with the resolution of the lesion. The seventh case is a 77-year-old white male with a history of cutaneous squamous cell carcinoma presented with a right inferotemporal corneal opacity with irregular border. HROCT again demonstrates that it is a hyperreflectivity and thickened epithelium with abrupt transition between normal and abnormal tissue. Histopathological examination discloses faulty epithelial maturation sequencing that extend up to near full thickness that is shown in between the arrows with a thin layer overlying mature epithelium. This is the case of severe dysplasia. The patient was treated with a topical interferon alpha 2 beta for 5 months with no response and then switched to the topical 5-fluorouracil with subsequent resolution of OSSN after 3 cycles of therapy. The last case is of 78-year-old white male with a history of multiple cutaneous squamous cell carcinoma presented with a right nasal corneal opacity with irregular border. HROCT shows that thickened hyperreflective epithelium with abrupt transition point. Histopathological examination discloses again faulty epithelial maturation sequencing that extend up to half of the thickness. This is the case of moderate dysplasia, corneal dysplasia. The patient was treated with 5 cycles of topical 5-fluorouracil with complete resolution of the lesion. Discussion. All the cases were of opalescent corneal lesion in the exposure zone with at least 2 of 3 HROCT characteristics suggestive of OSSN. 7 of 8 had a HROCT showing hyperreflectivity and abrupt transition and variable thickening. First 2 individuals with a metaplasia were black versus the OSSN group where all individuals were white. This is consistent with the previous studies that shows individuals with OSSN are more often white males in their 7th decade of the life. Some differences were noted in the clinical characteristic of the lesion, with irregular border noted in only 1 metaplasia case, while it is seen in the 3 OSSN case. To understand why the cases of squamous metaplasia seem similar to the OSN, on HROCT, the shared pathology finding must be considered. On histologically, OSSN shows hypoplasia, surface keratinization, loss of goblet cell, loss of cell polarity, nuclear hyperchromasia, pleomorphism, and mitotic figures. And in case of metaplasia, it shows some same features as the OSSN, including epithelial thickening, loss of goblet cell, and surface keratinization. These shared features between the 2 groups likely to explain the overlap in the HROCT. The strength of study. The key point of this study was to highlight that if a patient does not fit the demographics of the OSSN or if a lesion does not respond to the topical chemotherapy, an alternate diagnosis should be considered and an incisional biopsy should perform. Another strength of the study is that to highlight the limitation of the HROCT, that the inability to differentiate between the metaplasia and dysplasia of corneal lesion, which is important for clinician to recognize. If the treatment for OSSN is solely based on the HROCT or even confocal microscopy finding, it is possible that small subset of the patient with the squamous metaplasia could potentially undergo unnecessary therapy and procedures and can be prevented confirming the diagnosis by incisional biopsy. Limitations for this study is it is a retrospective case control study with a limited number of the patients. All the cases were corneal lesions and thus had a minimal epithelial thickening. In addition, the first case of the metaplasia was treated with a topical interferon alpha 2 beta before the biopsy, which may have affected the pathology result. Shadowing effect in HROCT seen in leukoplastic lesion as well as in all invasive lesions is not considered. Take-home message: in case of opalescent corneal opacities and HROCT finding that demonstrate features suggestive of OSSN, that is epithelial thickening, hyperreflectivity, and abrupt transition from normal to abnormal epithelium. The clinician should consider metaplasia in appropriate clinical setting. Histopathological examination remains the gold standard for the diagnosis of the OSSN, and incisional biopsy should be considered whenever needed. The Marie effect method. Study question is well defined. Study population is not applicable because very limited number of size of sample. Study period is well defined. It is a retrospective case control study. Assignment matched up for the baseline parameter. Assessment measure of outcomes are appropriate. No statistical test is performed. P-value cannot be assessed due to the less sample size. Extrapolation is not applicable due to less sample size. Thank you.
Thank you, Tejas, for a wonderful presentation. And I think with this, we would move towards the discussion. So I would just like the expert comments from our two eminent panelists, Dr. Swati and Dr. Swapnil. So, Dr. Swati, what is your take?
Tejas, just stop sharing.
Yeah, stop sharing.
Yeah.
So we would just like to know the comments from our expert panelist. So, Dr. Swati.
Yeah.
Just a minute. Tejas,
It's at
just
the top.
stop sharing. We can't see your faces.
Yeah, it's at the top. Red colored thing is there.
Yeah.
See, for sharing, it is at the bottom. Green arrow is there. So for to stop,
Yeah,
it
yes,
is
sir.
at-
I have found.
Thank you.
Yeah, Dr. Swati.
Yeah. First of all, thanks, Tejas, for presenting the article well. And thanks, Dr. Parul, for asking for the comments about this article. So I think first we have to understand that ASOCT, of course, is very helpful for diagnosis of OSSN. But there are more number of benign lesions as well, which can mimic the ASOCT features of OSSN, one of which is squamous metaplasia, which is being discussed in this article. But we also have other conditions like epithelial hyperplasia. That is one condition, again, where we cannot differentiate OSSN from just epithelial hyperplasia based on ASOCT, and also in solar elastosis as well. In all these cases, there will be some amount of epithelial thickening that would be there, and there will be hyperreflectivity. And because of hyperreflectivity, there will be an abrupt transition as well. Though the authors in that case 4, where they have shown that there is no abrupt transition, obviously there is abrupt transition between the normal and the abnormal epithelium, because the abnormal epithelium is hyperreflective, while the normal epithelium, you do not expect it to be hyperreflective, and that transition was clearly seen in that case as well. So all these features would be seen in any of these conditions that I have listed. The only way probably that will help us to distinguish, even based on the clinical pictures that the authors have used in this article, the OSSN, the corneal OSSN, it was much more kind of like, very thin membrane-like. While the squamous metaplasia, it was more like, it was very, it was thicker than what you have seen with the other OSSN lesions. And of course, as the authors themselves claim that they have much more well-defined margins as compared to that of OSSN. Usually OSSN, the classically for corneal OSSN, we describe that it has heaped up margins or it has feathery margins. These are classic features of corneal OSSN, which we do not see in any of the other benign lesions that I just mentioned, like in squamous metaplasia or epithelial hyperplasia, or even in solar elastosis. You do not expect to see these very, the heaped up margins are never seen, and also the feathery margins are not seen. The confusion comes when the corneal OSSN does not have these typical features of heaped up margins or feathery margins as well. So in such cases, of course, nowadays, it's not that every case of OSSN we do biopsy before we start topical treatment. But if it is not classic features like on clinical examination or on ASOCT, it is always better to do a biopsy. Though the authors have said that they've done incisional biopsy for such small lesions, I think I would just go ahead and just excise the completely, because hardly the lesions were all less than, I think, 3 to 4 mm. They were not large lesions. So in such lesions, I would rather go for excisional biopsy rather than just incisional biopsy. Yeah, so these are some of the comments. I think you're muted, Dr. Parul, in case if you're talking.
Yeah, thanks, Dr. Swati. Swapnil, being a cornea surgeon.
Yeah. So Dr. Swati has covered most of the points, but the as you know, Dr. Kenya said that the main aim of this JC is to make aware to general ophthalmologists what is going on in the field. So usually that's the scenario whenever we see such kind of studies coming up, that OCT, you see this kind of finding, and then you have the OSSN. People usually take that single message and then tend to diagnose based on OCT only. So the message is very much clear and loud with this article is that you need to look at any lesion comprehensively. Like you have to take into account clinical examination, incision biopsy. As I agree with Dr. Swati that for such lesions, incision biopsy, even I would not do that. I would rather take out the lesion as per the standard protocols and then send it for histopathological examination. And if you see in this article, even the case 6, they have mentioned that no case showed the vascularization and all, but you can see clearly in case 6 there are small corkscrew vessels, and that points more towards the diagnosis of OSSN. So I think again clinical examination is very, very important, and that's something which should not substituted by the any investigation like HROCT. It should be just an adjunctive. It should not be the diagnostic modality. It should be just to guide us about what is happening.
If I could ask a question from a general ophthalmologist point of view, what about rose Bengal staining and keratin presence in these lesions? Would that be a marker towards OSSN?
I think even the rose Bengal, or you can say lissamine green staining, they are vital dyes. Basically, they will stain the dead cells which are present on the surface of this kind of lesions. So again, it is very, very non-specific. This kind of dyes will stain even metaplastic lesions, or even the elastosis, or even actinic keratosis, which is seen because of sunlight exposure. So, Dr. Swati, any other opinion about this?
Yeah, I completely agree, Dr. Swapnil. I think any of these stains, even fluorescein for that matter, fluorescein, rose Bengal, or lissamine stain, or toluidine blue, these are all the different stains that have been used for OSSN, but they are less sensitive and less specific when compared to that of HROCT. OCT is much more sensitive and specific for diagnosis of OSSN. So these staining alone should not be used as a method to diagnose OSSN. Definitely, they're useful when you already know it is a case of OSSN to know the exact extent of the disease, especially the corneal extent. So for knowing the extent, it is useful, but I don't think it is useful to make a diagnosis of OSSN. I completely agree on that. And I think sorry.
Sorry, no, go ahead. I'm so sorry.
The second part also was the other question that was asked was the presence of keratin. Again, the presence of keratin is not very specific and sensitive for OSSN. Yes, many cases of OSSN do have keratin, but presence of keratin is not always equal to OSSN. For example, even you would get keratin even in cases of actinic keratosis. Actinic keratosis, of course, some of the articles, they include it under the umbrella of OSSN. But the OSSN, we should include only dysplasia, carcinoma in situ, and invasive squamous cell carcinoma. So so all these features like presence of keratin, presence of intrinsic vascularity, staining with any of these dyes, all these, they have to be used as only the, when you make a diagnosis as additional features rather than using them as a criteria to make a diagnosis.
Thank you so much.
Swati, I just had one. Which dye would you prefer? And can you just elaborate on the technique that you would use? and what kind of staining pattern that you see, because many a times when you use this rose bengal and lemon green, the staining is not that very great. So any tips on, using how you can use these dyes?
Yeah, I think first of all, like right now in most of the practices, people do not use these dyes as much as they would have been described in the past. Even in, sorry, yeah, even in my practice, it's like, first because it just spoils the photographs. So I don't use the dyes initially in the clinic. First, I get the photographs done, and then, of course, in some cases, I would want to use the dye, especially if as I mentioned earlier, to know the exact extent of the lesion. So, if it is a thick, nice, elevated lesion, this dye has minimal role. Any of the dye, for that matter, fluorescein or rose bengal or lemon green or toluidine blue, any of those. But if it is a very plecoid lesion, which especially happens if it is a corneal OSSN, where the lesion is like just a very thin layer. The plecoid lesion, in these cases, staining with any of these dyes is extremely helpful to identify the exact margins of the tumor. I would say that any of the dyes work well to identify the margins. It can be whatever is available with you. I'm sure like fluorescein dye is available with each of us. The fluorescein strips are available, and that itself is sufficient to delineate the margins. And again, it should not be too much of staining, too much of the dye that is like, kind of overflowing everywhere. Just kind of touch the tip, without without the patient having reflex tearing. That's always helpful. And it just with one blink, and it just kind of like stains the margins. It's helpful especially for the corneal plecoid lesions.
Dr. Swapnil, are you there?
Yeah, I'm here.
Yeah. Is it right to say that study probably has compared very early lesions of OSSN and metaplasia, and that is the reason for less specificity for HROCT as compared to higher OCT in larger lesions? So what would you say about it?
Yeah, I think they have compared completely different kind of lesions, right? So the kind of risk factors associated for squamous metaplasia are different, and risk factors for OSSN are slightly different. So I don't think they do have taken early lesions, because that's where the role of ASOCT comes in picture. It's if it's frank OSSN, then obviously the picture is very much clear. So they have taken early lesions where we are likely to confuse between metaplastic lesions and the OSSN. But yes, of course, they have stated very clearly that the OCT is not helpful to distinguish between them. And that's what they say, that if it is not responding to any treatment, you should suspect some other diagnosis and go for the incisional biopsy. In that case, I will say the complete excision of the lesion and histopathology. But yes, they have taken early lesions because that's where we are likely to confuse. In the frank OSSN, I don't think the clinical examination is enough to come to the conclusion, to manage the case.
So you need incisional biopsy in such cases, right?
No incisional biopsy. We will take out the lesion as per excisional biopsy. Exactly.
Yeah,
Parul, you're muted.
If you have a larger lesion, would you still go ahead and do an incisional biopsy? Because I'm surprised to see this incisional biopsy concept here. We always talked about excision biopsy. So any technique that we should, any tips so that we do not cause any spread out of the tumor? So Dr. Swati, if you have any exposure with the incisional biopsy in OSSN cases.
Yeah, so I think as mentioned earlier as well, the role of incisional biopsy in OSSN, at least in my practice, is only when I'm planning an extended enucleation or exentration for a patient that I want a histopathology diagnosis before I do a mutilating surgery. That's where incisional biopsy is usually done. If it is smaller lesions, or if the OCT, like according to the clinical examination or OCT, I'm sure of the diagnosis, I do not do an incisional biopsy. I would rather treat that patient with topical treatment if it is not an invasive tumor. If it is an invasive tumor, of course, I would go for a wide excisional biopsy. But I think having said that, it's very, very important that where there is ambiguity in the diagnosis, when we are not certain about the diagnosis, either based on our clinical examination or based on the OCT. If it is a larger lesion, definitely incisional biopsy would be an indication. But for smaller lesions, when it can be easily excised, especially if it is on the cornea, because on the cornea you're just removing the epithelium, which will regenerate very quickly. So if it is especially on the cornea, smaller lesion, I would rather just go ahead and do a alcohol keratoepitheliectomy in such cases. Maybe if it is a small lesion on the conjunctiva, and I'm not sure if it is OSSN or not, I would still consider incisional biopsy, even if it is a small lesion, because wide excisional biopsy, when we say on the conjunctival surface, we are going to lose almost 8 mm of normal conjunctiva. Because when we take out 4 mm on either side, which means we are going to lose 8 mm plus the size of the tumor, which would be 2 to 3 mm, even if it is a small lesion. So on the conjunctival end, when there is ambiguity in diagnosis, then incisional biopsy is justified. If it's a corneal lesion, we might as well just remove the entire lesion if it is small.
Just to add on, is there any role of these impression cytology and pap smear if you are really, wanting to know the cytopathology? So do they help us? And should we do it in our doubtful cases?
Yeah, I think that's an excellent question, because that's something which I'm sure every resident still reads in textbooks. But maybe they incisional biopsy. If there is any doubt about the diagnosis, go ahead with incisional biopsy. So you never get a conclusive diagnosis, even with a very experienced pathologist. And even if when we do it, it's only the superficial cells that we are getting, so it's difficult for them also to give us a conclusive diagnosis.
Yeah, so we have our statistical experts who have joined. So Dr. Siddharth, would you like to comment on the retrospective case series? Siddharth, are you there?
Yeah, Dr. Parul, thank you very much.
Yeah.
So as it's a case series, there are no statistics in it. So, but I'm just want to point out anybody who's trying to write papers that this is an example of a paper where the authors have published a negative finding. So the authors wanted to find out if HROCT is useful or not, and then they found that it is not useful, and they went ahead and published it. Otherwise, anybody who is writing a paper would be inclining towards trying to find a reason to say that HROCT has some role or something like that. But here they have gone ahead and published whatever they have found out. So that's the thing that anybody who wants to write papers should take home. That even if you do a study and you don't find a positive result, you can still go ahead and publish.
Thank you. Dr. Sengupta? Yeah, hi.
Dr. Parul, sorry, I've missed a lot of the presentation.
No problem. Yeah.
So, yeah, I'll just.
We're waiting for your killing comments.
Hopefully, I'll be able to deliver. Okay, so a couple of things. First is, like Siddharth has already said, there are no real statistics because there's 4 versus 4. Some critique for how the abstract is written, and it's a poorly written abstract. So, what is high resolution? People need to be more specific. Was it swept source? Was it time domain or spectral domain or whatever? And I don't see pretty much anywhere in the paper as to what OCT was exactly used. When you look at the method section, they say the clinical characteristics, HROCT findings in pathology was evaluated and compared. However, there is no comparison given at all in the results. The results have no means, have no p values, have nothing. agreed that 4 and 4 can't exactly be compared. But then, the important thing is, that inclusion really was that the HROCT should show features of OSSN. So, imagine that this is a study at Bascom Palmer from 2016 to 2021, that is 5 years. And they only saw 8 patients of this sort. It's like almost impossible to understand, isn't it? So if you take everybody with the diagnosis of squamous metaplasia and everybody with a diagnosis of OSSN, which is pathology based, and then you start looking back at the ASOCT, that is when you will actually get the right picture, isn't it? So, I fail to understand that only 4 and 4 were across the board like that, right? So these are like 4 diagnostic surprises, isn't it? That's pretty much what they are really trying to say. Unfortunately, the study design is relatively poor to at all answer these questions. Now I wanted to quickly look at the number of grants which are there here. So this is something different that all of you should try and look at when papers are published. So you see this name repeating again and again, Anna Gallard, right? So she's gotten grants from very large grants. So this is an RO1 grant. RO1 is like $1 million grant from NIH, which is recurring over 5 years. So every year you can get extensions of that. So she is a recipient of an RO1 grant. And so this kind of author is somebody who is somebody who commands respect. And if you look at who she is, she's on the editorial board of Ophthalmology Journal. Ophthalmology, like the biggest paper of all, right? So this is Ophthalmology Journal. She's on the editorial board of Ophthalmology, and papers from these authors are never going to be rejected, right? So that is something that, so even if Siddharth says that, oh, it's a negative finding, if you and me write about this, trust me, it's not going to get into cornea, right? So this is something that we should also think about. So if I have helped people submit papers with like a 10 case series or a 12 case series. There was one paper on post CXL infectious keratitis or something like that. It's not common, right? It's rare, and it's like 11 case series from like 3,000 eyes. So in a large institution that was rejected without a review in cornea, right? So because they said, oh, this keratitis looks very similar to all other keratitis that you see. And then, that was a negative finding, isn't it? That post CXL keratitis does not behave differently. So go ahead and manage it as you would. But then, that was rejected. So, when you have authors like this, so if you see none of the other authors have any funding, and so this author is hidden somewhere in between, generally these kind of authors will be the last and corresponding authors, though she is, but her name is somewhere in between, right? So papers from these authors are almost never rejected. The results don't tell us anything except for their HROCT findings are indistinguishable between 2 groups. Unfortunately, this is like the inclusion criteria itself, right? So I don't see much. So the real one sentence which appealed to me in this whole paper was, although HROCT is a powerful addition to workup and management of OSSN, there are instances of non-neoplastic lesions presenting with characteristics similar to OSSN on imaging. And this is pretty much what they're studying. So then they haven't looked back at all OSSNs and all metaplasias and their HROCTs. So then, something that we can't answer with this kind of paper. They say in a material method that clinical findings suspicious of OSSN. So what are those findings? So at least that is something that they could have given in the materials and methods. And this is what we say suspicious, and this is what we say confirmed. When you have these kind of authors who have written so much on these kind of topics, they can easily say, this is what we find as suspicious, and this is what we find as confirmed. So, a lot of the discussion that we've had just now after I joined is based on this. So then what is suspicious and what is not? What is not is something that they could have really given us. Again, they say that epithelial thickness, this is the only measurement that they have done in the whole study. And they say epithelial thickness of each of these was measured, and they have reported it as fold increase in thickening. That's really not the best way to do it. You just say this is millimeter and that millimeter. So 11 millimeters or 13 millimeters. But then every time they have said it is twice the size of the other eye or thrice the size of the other eye or whatever. But then it's always better to not do that and just report it as is. So these are some of the points that I thought in the limited time that I had to go over this paper, these are some of the points that I thought I'll share with all of you.
Thank you. Really wonderful.
Dr. Swapnil,
Yes, please.
do you think that using alcohol for epithelectomy will affect our histopathological reports?
No, I don't think so.
Okay.
I just can I share one case just I saw today, and it will show the effective use of OCT. I mean, it is how it is not useful. Can I share my screen?
Yeah,
Yes, go ahead, Swapnil.
please.
Yeah, I just downloaded Dr. Sengupta was talking. So this was the case I saw today in the clinic. And can everybody see this picture? I'll just zoom
Yes.
in. So it is like, a keratinized lesion with slight corneal extension, and I can see just barely any corkscrew vessel over here. He's a young chap, around 18-year-old. And then I got the ASOCT, and you can see here, it is not giving me any information. So because the corneal extension is just this much, you can say this is abrupt transition. Yes, this is. And then here normal epithelium begins, but then this is not giving me any information. So my management is still going to be based on this clinical picture. Here again, I'm not going to do any incisional biopsy. I'm just going to go and excise the lesion and send it for histopathology. Do you agree, Dr. Swati, on this?
Yeah, Dr. Swapnil. So can you put up the OCT?
Yeah. Here it is.
Yeah. Yeah, I think what we are seeing there, which is more hyper-reflective, is corresponding to keratin, I guess.
Right, it is keratin. It is keratin.
Keratin. And here, at least here, what we are seeing, it is mainly a subepithelial thickening that is there. So I think this can even be observed. It looks like a simple actinic keratosis, I think.
The guy who was referred to me, he has given up his food since last 7 days because he was told he has cancer in his eyes.
Yeah, if it is a very anxious patient, yeah, then best just
it has to come out tomorrow.
in exercise, maybe no need to go for 4 millimeters margin.
Yeah. It just, slight 2 millimeter margins. Yeah, right.
Dr. Swati, there's another question is that when you have a conjunctival OSSN, so in that, will HROCT be as good as we see it for corneal OCT? Corneal OSSN.
Yeah. Yeah, definitely. I think for corneal or conjunctival OSSN, for both, the ASOCT is definitely very, very helpful. Especially as I think Dr. Swapnil already mentioned, it may not be useful for the obvious lesions. When it is larger lesions, there is no role of OCT. But when it is these subtle lesions, when the lesions are very small, or when the lesions are plecoid, those are the lesions where OCT is very, very helpful. In fact, when we do, I'm sure that's the practice that most of the people who treat OSSN do, is that we do ASOCT each time, even when we are starting the topical treatment. And only based on the ASOCT findings, we stop the treatment. So we have to always confirm the the regression of the tumor based on ASOCT as well, because sometimes it may not be very apparent clinically, especially if it is a very subtle thin layer of the tumor that is there. So it is definitely useful for both the conjunctival component and the corneal component as well.
So another thing that I had in mind, so when you see sometimes benign papilloma, which is confused with OSSN, or you have certain conditions like xeroderma, or you have an existing degenerative conjunctiva like pterygium. So in these cases, will OCT make? I couldn't hear. Was it clear? No, my voice is muted. I'm speaking. Yeah. Hello, Dr. Swati, could you hear Swapnil? Yeah.
So I don't think OCT would be very much helpful in diagnosing the case. As I said before, the clinical signs would take the precedence. I mean, you have to look at the lesion clinically very well, and then come to some conclusion. And if you cannot
sit down. Look down, all right.
Zain, please.
Zain, please mute yourself.
Please mute yourself. Zain, you have to mute yourself.
Okay, Dr. Swati, in patients who have xeroderma pigmentosa, many times it's very difficult to OSSN from a non-OSSN.
Yeah. Yeah, I think in such cases, definitely, first of all, I think doing ASOCT in patients with xeroderma pigmentosum is very, very challenging because usually they're younger patients, sometimes they're children, and they're very photophobic. So it's very difficult for them to even open the eyes. So getting ASOCT definitely is first challenge. And once we have ASOCT, it may not be that we are certain about the diagnosis of OSSN. In these cases, the most common misdiagnosis that I see in my practice, at least where I get referrals as to rule out OSSN, one is the pseudoepitheliomatous hyperplasia. That is the most common misdiagnosis that I come across in my practice. Generally, there is less confusion with other conditions like the pterygium and all of those. There is less confusion. One, as I mentioned, pseudoepitheliomatous hyperplasia, that again, it has specific ASOCT features which help us to differentiate between OSSN and the PEH. I think I'm deviating from the question. Sorry, what was the primary?
So what did you
About
coexisting
xeroderma pigmentosa and
Yeah. So So in xeroderma pigmentosa, when we are not able to differentiate between the OSSN and other conditions, like sometimes they might just have limbal thickening and no tumor at all. In those cases, we are definitely justified in doing an incisional biopsy to confirm that, because as we all know, XP is very high risk for development of OSSN, and we don't want to miss them as well, because it might progress so much in one eye that the patients may end up losing an eye as well. So we don't want to miss those diagnoses. So we are definitely justified in doing incisional biopsy when we are not certain about the diagnosis.
And how do you do it? I'm so sorry. It's just a
Yeah. So it's always any incisional biopsy in general, it's always better if we have an area of normal tissue and the tumor tissue. So it's always better to do it from the edge of the lesion so that you are taking a part of the suspected tumor and a part of a normal area as well.
yeah.
And
Thank you.
also I think the comment or the question that was asked previously, whether it will cause spread of the tumor, it's less likely because already OSSN, if it is OSSN, it is an epithelial tumor. So it is already exposed to the tear film. So if it has to spread, the risk is already there. So it's not that we are disturbing any layer that might increase the spread. So I think it is okay if we do incisional biopsy in these cases.
Thank you. Smita, you have any questions?
you are muted.
No, I'm not muted. Dr. Smita.
Yeah.
Dr. Smith, actually.
Yeah. Is there any role of Octa in diagnosing OSSN? OCT angiography?
I have no experience.
Because I think there are certain articles which mention that Octa does help in diagnosing OSSN. So do you have any experience?
I have no
Yeah, if I can just
Swati?
if I can just add to that, I don't think the OCT angiography has any additional benefit of diagnosis in OSSN or other conditions as well. This is very similar to the retinal diseases as well, because even there, retinal and the choroidal also, the OCT angiography has not made any significant kind of progress other than the routine OCT. This has been studied. Of course, there are like isolated papers where they say that it may have a role of showing the increased vascularity and all of it, but it really doesn't help in the diagnosis. We have tried it, and it really, in my opinion, I do not think it has any additional role other than the simple OCT.
And what is the preferred choice, Dr. Swati, of chemotherapeutic agents you use?
Yeah, I think whenever available, and if the patient can afford, and more importantly, if the patient can store the drug appropriately, interferon is preferable. If the patient comes from a lower socioeconomic status and cannot store the drug, because interferon has to be refrigerated. So if they cannot keep it in a refrigerator, then 5-FU is the next best option. I personally do not use mitomycin C at all in my practice. I know there are people who use mitomycin C and they see good results with that. But I prefer to use either interferon or 5-FU, and it depends upon the patient whether they can maintain the refrigeration and they can afford the treatment.
Currently, Dr. Swati, interferon is very, very difficult to be, we are not getting it only. So I don't know whether the companies have withdrawn or is in shortage. Yeah, they stopped. So how, what is the other option? Do we have any other?
MMC, I mean, yeah, I do use 5-fluorouracil.
What is your treatment cycles, Swapnil, for 5-FU?
5-FU is concentration is 1%. You can use 3 to 4 times a day. And then again, like MMC, I do 1 cycle on, 1 cycle off, 4 cycles.
So you do 4 days or 7 days cycle on off?
7 days.
So how often do you see the toxicity? Because in last 2
very less. 5-FU very less. If you use MMC, you are definitely going to see in many cases.
I don't know. In the last 2 patients where I was not getting the interferon and I used 5-FU, both the patients, one of the patient had a severe epithelial toxicity and the other patient had a severe dermatitis within 7 days of 5-FU. I don't know, 4 times a day it was given. The first patient, obviously the 5-FU was for a longer period of time. So I don't know. I was recently I'm just seeing a patient and severe dermatitis. Dr. Swati, what is your?
Yeah. So if I could,
yeah,
if I add to what Swapnil has already mentioned, so the protocol that I follow is 1 week on and 3 weeks off. So they use only for a week, 4 times a day, and the next 3 weeks they do not use 5-FU. But it is very important to combine it with lubricants. When I say combine, not the reconstitution. Reconstitution, yes, you can use lubricant or you can use distilled water, whatever it is. But we have to tell the patient. So I specifically tell the patient that the 1 month they have to continue using lubricants. And the first 1 week when they use both the medication, they first instill the 5-FU. And then after 2 minutes, they instill the refreshed tears, or any of the lubricant drops. It's, I think, important to combine it with lubricants. And another important thing to mention to the patient is not to, because when we say, it's a cancer and you have to use drops, then patients are very over enthusiastic and they feel that they put more number of drops and it is going to go away quicker. So I think we have to tell them that please instill only 1 drop, because any spillage of that on the skin is definitely going to cause hypopigmentation of the skin. Dermatitis is known. It is going to occur in every patient where it is going to come in contact with the skin. So it's very important to tell the patient to instill just 1 drop in the eye. If it is the patient is not, if the patient comes back after the first cycle with a complaint of dermatitis in spite of us giving the instruction, then I tell them specifically just apply oil or Vaseline around your eye and just instill the drop so that the spillage effect is minimal. And also just to close the punctum for when they're instilling the drop. That is another thing that the instruction that can be given.
I think, thank you.
Can I ask a question? Yeah, wanted to ask if we compare 5-FU and interferon. Interferon is very slow acting. It takes a longer time. Whereas the 5-FU, on an average 4 cycles, almost the lesion is by and large gone. So what has been your experience? You have to explain the patient that this with interferon, it will take slightly more longer time.
Yeah, that's another very important and an interesting observation. I completely agree that with interferon, you may take a little longer for the lesion to go away. With 5-FU, with 5-FU and mitomycin C for that matter, with both these medications, the response is quicker. 5-FU is, of course, much softer on the eye compared to mitomycin C. So 5-FU would be preferable. Yes, it definitely has a quicker response. I generally do for interferon, at least because I know it's a milder form of drug, though it takes longer time for recovery, at least, but because it does not cause any ocular surface issues, I have the liberty to use the drug for 3 additional months after complete regression, which I do not do with 5-FU, because 5-FU I want to stop as quickly as possible because I don't want any ocular surface problems to set in. So I would just do maybe 1 additional cycle and then stop it. That liberty we may not be able to take with 5-FU that we can use for interferon. But yes, it definitely has a quicker response.
Swati, you had just one last one article where you had talked about more than 6 clock hours and less than 6 clock hours and its response to interferon alpha 2B therapy. So any just a quick comment on that also. So if you have a large lesions, would you still go with chemotherapy or?
Yeah, I think more than the extent of the lesion, I think it is the thickness of the lesion which is much more important. Because even if it is say it is spreading to 9 clock hours, but it is a very thin placoid lesion, then the response would be quicker. But if it is a thicker lesion, say even if it is in 2 clock hours, still the response to it would be slower. So more than I know I understand the article that you are talking about. We had in that article we had tried to look at what are the factors that might be responsible for the slower response of interferon, and in that just the size was the one which came significant. But that again, I would say that size, it's not just the number of clock hours. I think it is also to do with the thickness and also the histopathology as well. Because if it is a dysplasia or carcinoma in situ, then obviously they respond quickly for topical. But if it is an invasive tumor, then topical treatment is not something that would act well on the tumor. So it's a multifactorial thing how it responds to treatment.
Thank you. I think we have already shooted our time. So we would like to
could I ask Dr. Manish Sharma to give the vote of thanks for this meeting? And
Yes,
just to tell in one line, it was simply awesome to hear, and the points which were highlighted during the meeting were clinically very, very. There are a lot of takeaway points which I would definitely say from this meeting. Manish, please, you could give the vote of thanks. You're muted. Dr. Manish, just unmute yourself.
Thank you, Vaishal. Thank you. I would like to echo what Dr. Vaishal said. A lot of good takeaway points, and I would like to congratulate Dr. Tejas for presenting the paper, and a big thank you to Dr. Smita, Dr. Swapnil, and Dr. Swati for their expert comments. Dr. Sabyasachi and Dr. Siddharth for the statistical inputs. Sabyasachi in his inevitable style, and a big thank you to Dr. Vaishal and Dr. Parul Deshpande for taking the Journal Club forward. So thank you so much, and
there are
we'll
two
look forward to the next
people
session.
behind the scene. There are 2 people behind the scene, Dr. Zain Khatib and Dr. Neeraj Israni, who have always worked behind the scene, and we should thank them too.
Thank you.
Dr. Zain and Dr. Neeraj,
thank
please,
you, Zain. Neeraj and Zain, thank you so much. Zain was appearing and disappearing in between.
We'll take a photograph. We'll take the screen photograph of all of them. Rahul, could you do that?
Should thank Rahul also for technical support and Entod also.
Thank you, Rahul. Thank you, Rahul, and team Entod as well. Thank you, Santosh sir.
Now, next Journal Club will be in the month of August.
Yeah, it'll be on the 30th of August. And this time Zain and Neeraj are going to find out the topic and the college.
Yeah.
And if I may just add, we have a CME on practice management coming up on this Sunday along with the GBM
This
of
Sunday.
BOA. So a request to all those who are tuned in that please do join us at Hotel Hilton on 2nd July for that crucial CME.
MOS is also having a webinar on Friday evening on ophthalmic equipments, everything about ophthalmic equipments, especially tips for how to buy equipments, what is meant by lens bundling and all that stuff. And we have a galaxy of panelists right from Debashish Bhattacharya, MS Ravindra, and others from Maharashtra also, Milind Killedar, Dr. Bhushan, everybody is there. So please join on Friday at 8 o'clock.
Sure.
Thank you.
Thank you once again, Dr. Swati and Dr. Swapnil. It was a very good meeting and an interesting meeting with a lot of takeaway points. Thank you so much.
Yeah.
Excellent tips by Dr. Swati, and Sabyasachi was awesome actually.
Always. I was, he had told that he might not join, so I said,
no, but he must.
he
And
could.
in fact, that paper will be rejected by Indian Journal of Ophthalmology. So that shows the standard of Indian Journal of Ophthalmology compared to Ophthalmology Journal.
Yeah. Yeah. So I think, we conclude. Thank you so much. And thank you.
Thank you. Good night.
Fatima.
Good night.
Good night. Thank you, everyone.
Thank you, Vaishal and Dr. Parul and everybody for making this event.
Thank you, everyone.
Thank you, Dr.
Thank
Swati.
you. Thank you.
Thank you.
So much.